Next talk will be by Dr. HIMADRI Choudhury. He'll talk on medical management and intravitreal injections. Again, for those who have arrived late, if you want a handout of this session, it is there right in front of the dais.
Like this, you will have all the information about this. Whatever we are talking, this is it. So as Dr. Deepak said, I again repeat it, if you are in doubt, always treat case at the end of the do not take a chance.
Very good morning to one and all. At the very outset, I'd like to thank AIOC, the scientific committee, Dr. Deepak Mishra, Dr. Satangshu Mathur, Dr. Ajay Arora, Dr. Jalpa, and Dr. Haimanti for giving me this opportunity. We are all scared of this picture after a well-done cataract surgery or any other intraocular surgery. But once we have it, we have to know how to treat it. So what are the goals of treatment? To kill the invading organism, to arrest the damage by the exotoxins and endotoxins, and to arrest the host inflammatory response. What options do we have? We have the option of antibiotics in multiple routes, surgery, that is pars plana vitrectomy, and steroids. Now, intravitreal injection is the only surefire way to know that the drug will reach the vitreous cavity in the required concentration. Topical drops, subcunj injections, they are not adequate. You have to go for an intravitreal injection. Also, we use systemic medications. We will talk about that in the subsequent slides. Most of our knowledge of endophthalmitis is based from the results of the EVS study, but it came out way back in 1995. And there was a very important caveat. The EVS study included only those cases where the cornea was clear enough to perform a pars plana vitrectomy. So it means most of the very aggressive organisms were excluded from the study. Patients who had a corneal infiltrate were excluded from the study. So, however, the EVS study concluded that there was no role of systemic antibiotic, that immediate pars plana vitrectomy is not required when the visual acuity is better than PL, and only when the patient have a visual acuity of PL or less, only then you should go for a pars plana vitrectomy. However, there has been some it's not playing. It's playing, yeah. It's playing over here. So we now have to see what the role of systemic medication is. There are certain disadvantages. It prolongs hospital stay. It increases the cost. It might have some systemic side effects. But the ground reality is that most ophthalmologists feel more secure using an oral antibiotic. And systemic medications also prolongs the duration of the inhibitory concentration of the drug. And there is a better chance of killing all the viable organisms. There was a major review published in Survey of Ophthalmology in 2017. They showed a modified EVS protocol where they mentioned the algorithm of how to treat a patient with ENDOF. So the moment you diagnose a case as post-op ENDOF, a vitreous tap and an injection is essential. And they also mentioned the use of oral antibiotics, moxifloxacin or linezolid. Once the initial treatment is done, we assess the clinical response after 24 hours. If there is a satisfactory response, then we go ahead with the same treatment. And if there is a poor response, then an urgent vitrectomy is indicated. There is no role for a repeat intravitreal injection. Now, these are the most commonly used oral antibiotics, but we prefer ciprofloxacin, 750 milligram, 12 hourly. These are the organisms which cause end of coagulase negative staph, and delayed is mostly caused by Propionibacter acnes. There are certain indicators which indicate a very virulent organism. That is symptoms within 2 days of surgery, a light perception vision, APD, wound abnormalities, corneal infiltrate, loss of red reflex. Now, about the choice of intravitreal antibiotics, it actually depends on what organism you are suspecting. Now, for gram-positive, vancomycin is still the drug of choice. For gram-negative organism, although ceftazidime is considered to be the first choice, but still in case of very virulent organisms, we now go directly for imipenem or piperacillin tazobactam. This is because although most gram-positive are still responsive to vancomycin, but the case is not the same for gram-negative organisms. So if we look at studies from across the world, we see that in India, the organism profile is not the same as they find in the West. Here we have a very high percentage of patients who have a gram-negative organism, and among those organisms, a very high degree of resistance to ceftazidime and amikacin. So in those cases, when you are suspecting a gram-negative organism, we actually go for imipenem or a piperacillin tazobactam combination. Another important thing to know is that we should be aware that there is an entity called fungal endogenous endophthalmitis, mostly seen in COVID patients. So we have to know this entity because if we treat it as a non-infectious case with intensive corticosteroid therapy, things can get really worse. Now, vitreous biopsy is the suggested way. Vitreous tap is not recommended because vitreous biopsy avoids retinal traction, it avoids a negative tap, and it's not a very difficult procedure. I'll be showing how to do it. And alternatively, AC tap may be used. So everyone should actually perform a single port vitreous biopsy because it yields undiluted sample, especially when the visual acuity is better than PL. When you're not actually planning a pars plana vitrectomy initially, a vitreous biopsy is definitely essential. So these are the instruments which we use for vitreous biopsy. So I'll be showing how exactly to prepare the drugs. So I'll be talking about the preparation of vancomycin. We desire the concentration of 1 milligram in 0.1 ml. So vancomycin is available in 500 or 250 milligrams vials, and we initially have to dilute using 10 ml of sterile water for injection. So this is mixed with the vancomycin vial, and we have to mix it very well. And one point to remember is that we have to keep a lot of needles because we'll keep on changing needles at every step. So we draw 0.2 ml in a separate syringe. Then we make it 1 ml using distilled water for injection. But at every step, you'll notice you have to change the needle. So you need at least 10-15 needles with you to prepare 2-3 drugs. You mix it using this motions and allow an air bubble to move up and down the syringe. Then you take 0.1 ml, so that contains 1 milligram of the drug, cap it, and you also mark it to know which injection is which. Next, we'll be moving to the preparation of ceftazidime. Ceftazidime again comes in multiple concentration. We desire the 2.25 milligram in 0.1 ml. So for a 1 gram vial, we usually use 4.4 ml of distilled water for injection. Again, first we mix the distilled water along with the ceftazidime vial. Then take a new needle every single time. Take 0.1 ml initially, then make it 1 ml. At every step, very important to remove the needle because otherwise the concentration is changed. Again, we have to mix it using this round and round motions and keep finally 0.1 ml, which contains 2.25 milligram of the drug. Going to the vitreous biopsy proper, ENDOF is a very painful condition, so it's always advisable to do a perivalvular block in these patients. So it's done in the usual way, but very important to note that we should not put any pressure on the eye because these are post-op cases. Any pressure on the eye can lead to a wound leak, which is not desired. Dressing and draping is done like we do usually using povidone iodine. We put in a speculum. Here I'll be talking about preparation of the vitrector. So a vitrector comes with every phaco machine. Initial few steps are same. You have to put it into the machine in the way they have mentioned. Use aspiration and irrigation, and the rest of the steps are very similar. you have to put in a separate needle, but we don't use the infusion at all. So initial priming is done as usual. Only thing is, you need this yellow adapter. It comes with any IV cannulas. You use it to basically aspirate out the vitreous sample. We do not need the infusion, so you have to keep it separately. Now, use a trocar to mark 3.5 millimeter from the limbus. If you do not have access to a trocar, MVR, you can use a MVR to make the port. So single port vitreous biopsy is not a very difficult procedure. Once the port is made, we have to be sure that the cutter is actually cutting. So you first of all check the cutter, and only then you have to put the cutter inside the eye. Initially, you start with cutting, and then tell your assistant to start aspirating after a little while. So we do not need too much of a sample. Only 0.5 ml is adequate. Or the moment you notice any hypotony, you have to stop aspirating. Once the sample is collected, you have to cap it and send it immediately for the microbiological evaluation within at least 30 minutes. So you have to cap it, and we bend the needle as well, and immediately send it off for evaluation. Now, doing the injections, you need separate needles, separate syringes, because these drugs interact and can form a coagulum if you use the same syringe. So you have to do it separately. Injection is done very slowly in drop-by-drop fashion. Once the injections are done, we always try to keep the eye slightly soft so that it's not very hard. Once the injections are done, just check whether it's a self-sealing or not. And if it's self-sealing, then fine, but otherwise, suture can also be placed. So even very virulent cases do well with just a vitreous biopsy and an injection. So there are certain indications where we directly go for a pars plana vitrectomy instead of the vitreous biopsy and injection. So when the visual acuity is very less, PL only, a suspected highly virulent organism, when there is no response to intravitreal injection, in post-traumatic endophthalmitis and fungal endophthalmitis, we directly go for a pars plana vitrectomy. Also in delayed endophthalmitis. So I'll just be touching upon a few steps. Make sure that the infusion cannula is inside. Make sure you can actually visualize the infusion cannula. If you need, you can actually clean up the AC if you have to do that. And we perform a very limited core vitrectomy. We do not need to do a PVD induction, and just the posterior pole should be visible. The moment we can see the disc and the posterior pole, we stop. We do not need to perform an extensive vitrectomy. For most cases, just a limited core vitrectomy is good enough. So once the core vitrectomy is done, the moment I see the disc and macula, we'll stop. Once that is done, we remove the other trocars and we do the injections like we mentioned. Again, if there is any doubt, you should always be ready to put in a suture. So this was a traumatic end off, but patient did very well. So one thing you all should know is this E-kit from Oral Lab. So E-kit actually has all the medications and all the equipment necessary for the injection. So everyone should at least have that E-kit with yourself. So about the role of steroids in bacterial endophthalmitis, definitely there is a role. It helps to reduce the host inflammatory response. And it can be given in multiple routes of administration, that is topical, systemic, even intravitreal. But for fungal endoff, we do not use steroids. These are the microbiological workup that needs to be done. Delayed post-op endoff, again, need a pars plana vitrectomy and also sometimes lens removal, explantation, because only injections, they have a very high recurrence rate. So to summarize, early diagnosis and management can save most eyes. Intravitreal injections, vancomycin and ceftazidime are still used in acute endoff, unless we are suspecting gram-negative, when we use imipenem. AC tap or a single port biopsy is good for microbiological workup. And in patients who fail to respond to initial therapy, no use of doing another injection. We have to go for a vitrectomy immediately. Thank you very much.
Thank you, Dr. Himadri, for this extensive talk. Mainly the preparation of that intravitreal drugs and all, I'm sure it will be very helpful for